this talk and the food has been supported by a grant from the Center for Humanities in the Public Sphere, a grant from the National Network of Libraries of Medicine, and then with support from individuals like Dr. Paulette Hahn and Pamela Gilbert, and then finally from the Health Science Center Libraries. So welcome everyone. I would encourage you all to fill in one of the green sheets. It's an evaluation form that we use in developing programming for the libraries, just what things you want to hear about and what events you'd like to see us present. It's also my pleasure to introduce Michael Blackie. Dr. Blackie is an associate professor of family and community medicine at Northeast Ohio Medical University, or NEOMED, where he co-directs the longitudinal course, Human Values in Medicine. He received his doctorate in English from the University of Southern California, where he also taught narrative medicine electives at the Keck School of Medicine. His scholarly and teaching interests include death and dying, health humanities, narrative medicine, narratology, and sexuality and difference. He is the book review editor for the journal Literature and Medicine, and the editor of the Literature and Medicine book series published by Kent State University Press. Welcome, Dr. Black.
Thank you. Thank you. First, I want to thank Nina and all of her colleagues for their hospitality and inviting me to come here. This is my first time in Florida, so I'm still waiting for a gator moment. So I'm hoping tonight I'm going to have that encounter. So my title, I'll admit right up front, is a little clunky, right? But in conversations with Nina about what I would present, because I teach at a medical institution, we thought it might be useful for me to talk about how the rest cure might be of value for medical education. And so this is the clunkiness. So how understanding the rest cure and interpretations of it promotes the value of humanities and medical education. And I'm going to spend a lot of time about the interpretations of the Weir-Mitchell rest cure, which I'm assuming from the other speakers on the lineup that you've heard some about. Okay, so to begin, for today's lecture, I want to make the case that an examination of the ways humanities scholars have interpreted the rest cure, S. Weir-Mitchell's popular and problematic treatment for nervous disorders like hysteria and neurasthenia, primarily through Charlotte Perkins Gilman's representation of it. That I want to argue that it offers compelling justification for the incorporation of the humanities in medical education. To that end, I will focus on three specific moments in the rest cure's history. The first, the actual rest cure developed by Mitchell, as opposed to the one represented by Charlotte Perkins Gilman in the yellow wallpaper. Secondly, photographic representations of patients who underwent the treatment. And then finally, a symposium of physicians who convened to debate the merits for treating nervous women. To start off, though, Mitchell left behind a vast and rich archive of public and private writing that humanities scholars have interpreted in fascinating and conflicting ways. These interpretations amount to, I will argue, patterns of reading that, when taken apart, reveal the degree to which any interpretation, any reading of a text, be it a piece of literature, a clinical encounter, or even the human body, is determined by context, and more problematically, can involve projection or prejudice. I'm very interested in the way evidence is read. And evidence is very, very important, as you know, in medicine. Ultimately, I want to make the case that the interpretations of the rest cure illustrate the inherently vexed nature of evidence, and that an appreciation of this vexed nature has value for medical education, especially given the increasing emphasis on interprofessional healthcare teams. In such teams, each professional brings to the clinical encounter a particular way of reading. So a social worker might see the clinical encounter very differently than, say, the pediatrician. What counts as evidence, and what should we be focusing on? And I would also argue that these same clinicians have a different definitions of what evidence is. I will then make this case by examining the Weir-Mitchell rescue, paying close attention to how humanities scholars have either read or ignored, or, and I use this advisedly, misread the history or the evidence surrounding the Weir-Mitchell rescue. So let's begin with the two central players here, S. Weir-Mitchell and Charlotte Perkins Gilman. In particular, how Gilman's depiction of the rescue became the summary text, thereby eclipsing other interpretations of it. So the first quotation I'm going to start with is from Mitchell, one of his very influential books, and this is really the book that solidifies his reputation as the father of American neurology. She was emotional and ashamed of her tears and honestly hated the whole matter of sickness. You will see such hysterical women. You will see others whose minds are like the back of a piece of needlework with a baffling absence of pattern. And those of you who are familiar with the yellow wallpaper, our narrator in there is very interested in the patterns of the wallpaper and their absence of design and pattern. So then we'll move to Gilman's narrator, and she says, I will follow that pointless pattern to some sort of conclusion. Okay? So I'm going to use these two quotations as a kind of a tension. Despite the shared interest in baffling and pointless patterns suggested in these quotations, few cultural figures from the late 19th century America seem more at odds than S. Weir-Mitchell and Charlotte Perkins Gilman. Not only does the depressed narrator in Gilman's The Yellow Wallpaper fear being sent to Mitchell for one of his cures, should she not pick up faster, while under the care of her physician husband, Gilman herself directly criticized Mitchell's treatment. Quote, the real purpose of the story was to reach Dr. S. Weir-Mitchell and convince him of the error of his ways, end quote. Even a cursory look at his public life clearly indicates that Mitchell's errors extended beyond his medical practice. A staunch Victorian until his death in 1914, Mitchell spoke out against women's suffrage and advanced university training. Quote, I believe that if the higher education of the college life in any way, body or mind, unfits women to be good wives and mothers, there had better be none of it. So you can imagine right there, right, this is really good evidence for taking this man to the max, right, for his ideas. Women for Mitchell were more than angels, that 19th century representation of the perfect woman. Of the house, they embodied home itself. Most folks think vaguely of home as meaning marriage, husband, wife, children. But for me, its foremost and most beautiful human necessity is a woman. And indeed, this is of her finest nobleness, to be homeful for others. And it's interesting, they're homeful, where home and body, womanhood all become one, right, a kind of composite. He's coined a word. And to suggest by the honest sweetness of her nature, by her charity and the hospitality of her opinion, such ideas of honor, truth, and friendliness as clustered like porch roses around our best ideas of home. Throughout her career, Gilman challenged the images Mitchell celebrates here. Her fiction and her feminist treatise, Women in Economics, published in 1898, and The Home, Its Work and Influence, published in 1903, insists that as long as women are associated with, quote, sublime devotion to home and mothering, they are condemned to a morbid, defective, irregular, and diseased existence, end quote. Ironically, if not for Gilman's depiction, fictional depiction of the rescuer in The Yellow Wallpaper, most readers of American literature today would probably know nothing of Mitchell's treatment. Gilman's story has come to represent the prevailing view of an extremely popular and successful treatment for numerous nervous disorders at the turn of the 19th century. This was not always, that's actually too soon. This was not always the case. When The Yellow Wallpaper was published, most readers would have been familiar with Mitchell's work as a physician and a novelist. He wrote 13 novels, and had several collections of poetry printed. They would have known his work more than Charlotte Perkins Gilman. By 1892, when the New England magazine published the Yellow Wallpaper, Gilman was treated in 1887. Mitchell's patients were coming from as far away as California to seek his help in Philadelphia, where he practiced. When possible, Mitchell brought his rescuer to his patients, as one Bostonian noted. Weir Mitchell, quote, "Weir Mitchell has been here curing all the dilapidated Bostonians. His coming makes a great sensation, for he is a very famous man," end quote. Nervous invalids from across England and Europe began making pilgrimage to Philadelphia in the 1880s. Appreciative patients encouraged Mitchell to run for president, made large donations in support of his project for the benefit of treating nervous women, and even wrote him poems of praise. And here's that slide. In the city of Penn, at the Schuylkill's dark waters, and I'm sure I'm not pronouncing the river correctly. Is that okay? All right, that was a Philadelphian there. A world-renowned rest system has its headquarters. At last some bright day, a young day at your door will appear the famous neurologist, Dr. Weir. A poet-writer of much versatility, producing fine books with utmost facility. And there is debate whether his books are really all that good. There are 13 of them, and they can be pretty dry. Dr. Mitchell's opinion, you equate to receive it. He says you'll get well, and you'd like to believe it. Mitchell received hostile criticism as well, and he was called a charlatan and a quack well before Gilman wrote her famous story condemning his methods. But his pivotal role in Western medical circles and in American letters from the Civil War until his death on the eve of World War I more than answer these charges and, more important, exceed the limited scope afforded to him in Gilman's fictional depiction. Following the reissue of the Yellow Wallpaper in the 1970s, the rescue has been interpreted primarily as a symptom of male Victorian medical establishment's desire, quote, to reorient female neurasthenics to a domestic life, end quote. That is, as a cure to pacify active female imaginations at odds with dominant male codes. In Gilman's story, and in most of the criticism generated by it in the last 40 years or so, Mitchell's rescue exemplifies the oppressive Victorian standards of late 19th century America. For example, and here are some examples of this criticism. The story is read as, quote, an indictment of the incompetent medical advice Gilman received, end quote. Its depiction of the rescuer provides a context to, quote, expose the sadistic standard white middle class process by which a grown woman under the supervision of a benevolent male expert was required to turn herself into a helpless, docile, overgrown infant, end quote. At least one critic acknowledges that, quote, Mitchell was quite popular among his women patients. And recent scholarship is getting into this. There were very kind of productive relationships between Mitchell and some of his female patients. Only to concur with scholars who view Mitchell's rescue as a means of subduing women who have strayed from their domestic role. These readings stop short of examining the highly orchestrated practices, however, essential to the rescue. This lapse is especially apparent in the case of the critic charging Mitchell with sadism, who drew her conclusions, if we can rely on her bibliography, without consulting a single document from Mitchell's published work. Because she claims, quote, the aggressive sexual content of the classic rescue is obvious, end quote. Now I just want to unpack that a bit, that evidence is never obvious, right? As soon as we think it's obvious, we're missing our opportunities to apply critical thinking to it, to pay attention to how it signifies, right? Taken collectively, a distinctive pattern emerges out of these readings that renders indistinct other interpretive and historical perspectives about the rescuer and Gilman's responses to it. And though this pattern has been challenged and revised recently, I am thinking in particular of Helen Horowitz's Wild and Rest, of which the exhibition I think was based largely on that came here, and Nancy Cervetti's really wonderful biography, new biography of Mitchell. Despite this, the interpretive and historical value of Gilman's fictional and autobiographical denunciations of the rescuer remain quite influential. For reading practices, most of which that come out of the humanities, that take upon themselves the enterprise of exposing the plight of a captive female imagination under patriarchy in general, and 19th century medicine in particular, these critics, for the most part, avert their critical eye from the status of real female bodies that came under Mitchell's care. Part of this aversion is, of course, the result of Gilman's story, the focus she takes on her story, by honing in so strongly on the confused interior states, the psychic traumas of the narrating protagonist as she undergoes her prescribed rest cure, rather than focusing on her outwardly bodily state or its treatment. Gilman's text encourages its readers and detractors who come to it primarily through the story's filter to overlook the flesh and blood body, the maternal manifestations of health so central to Mitchell's own diagnosis and cure of his female patients. These readings of the Yellow Wallpaper have become the dominant interpretive model for understanding the rescuer's substantial history. In contrast to these readings that are based largely on an acceptance of Gilman's depiction, the mountains of evidence of the actual rescuer and Mitchell's delivery of it present a much more complicated picture. When I began researching the rescuer's history for my dissertation some years ago, I had what I call a clarifying moment. I was at the library of the College of Physicians of Philadelphia, digging into the archival material on Mitchell and his treatment. And it's kind of amazing if you ever go to this library, as you walk up these marble stairs, there's this huge oil painting of Mitchell right at the top, right? It's his domain in many ways. He helped found the library. The evidence suggested that the image of Mitchell and the rescuer bequeathed to us from Gilman and endorsed by decades of humanities scholarship was only part of the story and a particularly biased one, right? It saw this evidence in a particular way, always through the filter of Gilman's story. The more I researched, the more I became aware of how vexed the actual history of the rescuer was and how often readings of Mitchell's treatment followed a predictable pattern, a kind of interpretive game that I came to call naughty medicine, naughty doctor. Okay, and in this game, it begins with the assumption that medicine is always oppressive and that doctors are the oppressors. It ends once enough evidence has been gathered to support that assumption. And when I was doing my early work and doing conferences, there was often this refrain in papers and pieces that you would hear like, and yet again, we see medicine doing this, right? It was just this kind of predictable way of reading the evidence. Medicine has committed atrocities to be sure, and there have been and always will be unscrupulous doctors. But to expect the health professions to practice somehow outside their historical moment is to miss the opportunity to improve medicine in our own time. I think we need to pay attention to context always. And at this moment, I'd like also to comment on my own identity as a scholar. Literary scholars trained me. My doctorate is in English literature. I have, however, never taught in an English department. Before coming to Northeast Ohio Medical University, or NEOMED, I co-directed the Center for Literature and Medicine and taught in the Department of Biomedical Humanities at Hiram College, a small liberal arts college in Ohio. My professional career has been largely focused on preparing students for the health professions. That focus, especially now that I am at a medical university, has meant that when I criticize medicine, I do so cautiously, not because I fear reprisal, biting the hand that feeds me, right? But rather because I appreciate the complexities riddling the practice of medicine and how these complexities influence students, residents, and even senior clinicians, right? That they were always working within the constraints of context. In contrast to Gilman's depiction of the rest cure, the actual treatment designed and practiced by Greer Mitchell was comprised of 6 to 8 weeks of absolute rest and isolation from family and friends, a closely monitored diet consisting mostly of large quantities of milk aimed at increasing the body's weight, and massage and electrotherapeutics to keep the muscles stimulated and flushed with blood. So here are a couple slides where the popularity of Mitchell's treatment can be documented in how it was disseminated. There were places like Restland, vacations, or health, right? So imagine you go someplace and the objective is you're just going to rest, okay? This was a place in New York, in Dansville, which I believe is in, yes, in New York. Here is the Sunnyside Farm Rest Cure. All young women here. There isn't a clear sense what the regimens were at these locations. This is my favorite. This is the static electric rest cure. So harnessing electricity at the same time that you are resting. The cure's history reaches back to the Civil War when Mitchell first began feeling exhausted and nervous, overwrought soldiers with forced rest and full feeding, and this is Mitchell examining a Civil War veteran. After the war, Mitchell added the remaining techniques to his regimen and turned his attention to a wide range of nervous complaints suffered mostly by women. Mitchell believed that the baffling absence of pattern characterizing the minds of his nervous patients stood between him and the healthy individuals he wished to reclaim from, quote, the rack of sickness, end quote. To reach that salubrious end, he focused primarily on the patient's body with the belief that by rectifying the visible signs of nervousness, such as loss of weight, color, and stamina, a woman healthy in body and mind would appear looking to return to the metaphor at work in the quotation I cited earlier, like the front of a piece of needlework, a discernible pattern in place and the contours of the self clearly discernible or visible. Rest cure bodies displayed visible and tangible signs to which Mitchell attributed tremendous diagnostic and prognostic value. He marveled unabashedly at the fruit of his therapeutic labors. His enormously successful book, Fat and Blood and How to Make Them, contains 29 case histories, each one a slender composite, but their accumulative effect summons to the reader's mind a parade of female bodies, each one monitored, fed, rubbed, and electrocuted until fattened and invigorated. So here are the 3 examples. Miss L, 29, height 5 feet 8 inches, weight 118 pounds, in 4 months became perfectly well, and rose in weight to 169 pounds. 2 months were spent in bed. Miss E, a nervous, morbid invalid, with a threat of insanity and a wretched state of mind, became quite florid and rose in weight to 132 pounds from 119. And finally, Miss M, 32, at one time a bright, cheerful woman, had a slight fall and some moral strains, which speedily reduced her to a state of invalidism and made her so irritable and morbid that she became a source of misery alike to herself and others. She was well cured in 9 weeks of rest and became of good color, but did not gain over 7 pounds. These compendiums emphasize production. They move quickly from a generalized summary of the patient's infirm state, occasionally remarking on its antecedents, to computing the cure's desired finale, increases in fat and blood. Mitchell saw then the patient's body, especially its outer appearance, before and after the cure, as a primary actor in a story of health lost and regained. And I don't want to suggest that the way Mitchell's using these descriptions, that evidence isn't itself problematic, right? And that it doesn't speak some truth that doesn't also need to be unpacked. It does, absolutely. I now want to turn to an album of photographs presented to Mitchell by William S. Playfair. He's the British obstetrician that brought the rest cure to England in the early 1880s. These images capture patients' physical states before and after undergoing treatment. And so as I go through them, if you have any comments or you make any, you want to make any kind of observation, please do. So there are always these before and after photographs, okay? So on the left, obviously before, on the right, after. And you can see how emaciated or this living skeleton. I'll quote a practitioner later in the talk who says that these patients often look like living skeletons. This one clearly in bed, right, as an invalid. And then here, what's kind of interesting, Playfair seems to have also included the talents of a hairdresser and dressmaker in his rescue, because the after pictures were always, they're coiffed and they're in dresses and such, looking much more feminine, right? And this is part of the critique that the rescue produces this feminized woman at the end, right? The homeful woman.
I have a question.
Yes.
Sorry. So how many of these patients do we know, like, if they had an eating disorder, such as anorexia or bulimia? Because
Right.
they look like they may have had an
Absolutely.
eating disorder on top of maybe a neurological issue as well.
Right, right. I'm going to get to a couple pictures here in a moment to get to this, and so I'll wait till they come up, and then I'll try to get at that. This is the last, I believe, in the series that Playfair sent to Mitchell as proof of the rescuer's value. They were never published in while the physicians were alive. Now, here's the last one. So this gets at your question. Now this, William Gull, who was a practicing gynecologist, coined what he thought was anorexia nervosa, right, for these patients. Mitchell, as did Playfair, rejected or resisted this diagnosis. They were committed to this notion of neurasthenia. Mitchell didn't like hysteria either. He said it would be better called mysteria for all that it actually tells us, right? There were so many different symptoms at work in hysteria. And neurasthenia, too, is just this crazy collection of symptoms, right, for nervous disorder. But
did he have a feeling that they, in the state before they went to the rest home, that they weren't staying within his guidelines of being a woman, and that was part of the problem?
Yeah, and this is definitely how part of these images and the rescue has been read. One way it's been read is that by refusing to eat, if that was the primary cause of their state, their health, their poor health, right? That was a rejection of what the expectations were for them, right? And this is a kind of dialogue that continues around anorexia nervosa still, right? That it's a refusal of participation within kind of standard notions of femininity, or it's a hyper expression of femininity. This notion that you have to be so thin.
Or they could have produced or shown as anxiety.
Yeah, absolutely.
Something other than.
Which is, again, the problem here is that for Mitchell was that there's so many conflicting possible explanations for why these women were in these states. So let's just focus on the body and have her pay attention to her body as it fattens, right? And that be the focus. What I think is kind of interesting, if we think about shows like The Biggest Loser, this is the flip side of it, you always get the before and after, right? And it's as if that after, when you think about those after pictures in The Biggest Loser, the men and women are always ripped, like hyper athletic, none of which is necessary for health. Those are aesthetic gains, right? Health is not determined by how ripped your muscles are, right? So it's interesting how the body becomes this strange piece of evidence for a projection of wherever we are as a culture and what kinds of values we want to attribute to it. And I think what you get with these patients, though, is it is very much an embodiment of those anxieties within culture. And so this is the after picture, again, now in a dress and such. This is published here. This is a man who went through a rescue as well, was suffering from neurasthenia. And it's kind of a loincloth thing. He kind of anticipates Tarzan, I think. He's this kind of like, he's a little early, it's like 20 years before Tarzan. But interestingly, Gilman also seems to have accepted the logic that her body would suggest her illness. This picture is one taken before her rescue. And this is at the Schlesinger Library. On the back of it, scribbled, and there's some debate whether or not it's Gilman's writing or not, says, "This is what my rescuer did to me." Right? And so she is suggesting, right, again, that the body can be read in this way as clear evidence of an outcome. The dramatic changes these images document were the same Mitchell drew his patients' attention to while under his care. Indeed, Mitchell encouraged his patients to study closely the cure's steady composition of visible somatic signs, to read in them a future free from the rack of sickness and the despotism of ungoverned emotion. He saw the patient's body, especially its outer appearance, before and after the cure, as the primary actor and subject matter in the therapeutic process. Because their patients' nerves had been fatigued to such a thorough degree, rescue practitioners believed that securing structural and functional repair required putting all of the tissues of the body, including those of the brain cells, temporarily out of commission. And Mitchell often referred to this as putting the sensorium in splints, kind of interestingly drawing a connection between the sensorium and a limb that is in a cast, say, that's been broken. At the practical level, stasis was required if these repairs were to be achieved, but stasis also functioned to affect a cure in dynamic ways. Practitioners describe disease and recovery undergoing a series of movements beginning within the static body's interior and reaching outward. Just as a patient's exhausted appearance signified the existence of depleted nerves, a similar process of deduction typified the thinking of rescue practitioners when they evaluated the products their labor had wrought, fat and blood, in the same patient. These highly visible signs pronounce the healthy regeneration of the previously damaged nerve tissue. As depleted nerves regained health, vitality returned to the body's exterior. But the ways in which Mitchell and his circle perceived this transformation reached beyond the cellular. An analogy drawn between the patient's body, its fattened surface, and her mind underlined the rescuer's therapeutic logic. A logic that authorized deducing the latter's well-being from the state of the former. For even though a patient might be forced to lie in a static state for weeks, her body was imagined as an active site wherein therapeutic measures were continually drawing wholesomeness to its surface. Successful treatment demanded of the patient, in anticipation of this outcome, that she restrict her attention to her body's outward aspects, as it was massaged and electrically stimulated by the nurse, and watch it along with the physician as it fattened and blushed. Ideally, the cooperative patient became a kind of voyeur to her own objectification in the quest of calm subjectivity. Thus, what counted as a cure rested almost entirely upon surface meanings. Practitioners wedded themselves to a logic that in nearly every case granted visible signs the status of undeniable proof of wholesomeness, of a wholesome interior, excuse me. Rescue practitioners sought to replenish, quote, the picture of the living skeleton, and I think the before pictures give us a sense of that, brought by some revolutionary disease with mountains of adipose tissue flowing with red blood, the material, quote, out of which is formed our bodily frame, end quote. Mitchell's focus on the body at the expense of the mind, however, a criticism leveled at Mitchell toward the end of his life and explored at length by humanities critics more recently, should, I would say, be seen in context. Historically, we must remember that an appreciation of psychology was not established during the heyday of the cure. Interestingly, however, if you know the yellow wallpaper, the narrator says to her husband, who's also her physician, that he's saying that she's improving. And she says, better embody, perhaps. Beginning to draw that distinction between better in body but not in mind. And the narrator's husband, physician, says, never think of that. Never make that distinction, right? He did not want there to be a distinction between mind and body. They had to be conflated as one. With this interpretation of the rest cure in mind, and again it's mine or looking at the evidence, I want to look back at a touchstone in the cure's history, a symposium that examined the best course of treatment for nervous women held in Philadelphia in 1892, in order to further make the case for how the evidence surrounding the rest cure has been read to favor certain established ideas or prejudgments. Most important, perhaps, is how this debate helps us appreciate what the cure meant for many women who underwent Mitchell's treatment. Leading up to the symposium, Mitchell's treatment, though grounded in the emerging field of neurology, shared with gynecology a tradition that sought to blame the appearance of nervousness or nervous symptoms on a lesion, some kind of morbid tissue, usually existing somewhere within a woman's pelvic region. Mitchell's early writings recount the routine use of gynecological examinations to determine whether or not his nervous patients exhibited ovarian or uterine disorders. But he turned to these procedures after commencing with the rest cure's regimen rather than before. Implementing treatment did not follow the examination of a woman's pelvic region. As early as 1881, Mitchell outlined a battery of questions all practitioners of his cure should consider before proceeding with local treatment, gynecological treatment. Quote, the first question you will have to settle is as to whether it be wise when using this treatment to correct all womb troubles at once, or to wait or to neglect them altogether, unquote. The patient's marital status and the likelihood of sexual activity dictate whether or not Mitchell will make or cause to be made a thorough examination, unquote. Depending then on the diagnosis, Mitchell would forego gynecological procedures and focus exclusively on administering a rest cure, or, quote, if the case be of extreme feebleness, he would delay all surgical intervention until the improved outcomes which follow treatment offer a better chance of successful mechanical interference, end quote. If the patient be a virgin, he argued, there seems little reason to suspect misplacements. Mitchell put all trust in the outcomes produced by the rest cure. Should indications of misplacements exist, and quote, the patient be of a temperament which makes vaginal examinations disastrous shocks to the nervous system, end quote, he waited patiently the result of the rest cure and its aids. Only after 2 months of such treatment would Mitchell attempt local relief, hoping that with the reinforced nutritive life, the patient may bear the strain. In numerous cases, the rest cure did the work of local treatment. By the 1890s, Mitchell relied even less on gynecological procedures. Transcripts from this symposium held at the College of Physicians document that physicians who aligned themselves with gynecology routinely advocated for local treatment, while physicians who favored focusing on patients' nerves, with Mitchell as their leader, cautioned that such diagnoses were often hastily made and insisted that the rest cure offered a far less invasive and much more productive method of alleviating women's nervous symptoms. In the following summary of the symposium, I'm using neurology, neurologist for simplicity's sake. Nowhere in the transcripts do these physicians identify as such, okay? I just use them here to distinguish between physicians who clearly identified with the field of gynecology and those who aligned themselves with Mitchell's work with the nervous system. In pleading their cases and in describing their respective gynecological and neurological procedures, the symposium participants exposed the putative patient's body to a series of diagnostic gazes in order to claim their particular territory. Gynecologists prone to counting the number, quote, of diseased appendages, end quote, in nervous women, posited a clear-cut cause and effect relationship between an aberrant pelvic region and a nettled nervous system. They admitted to the rest treatment's therapeutic logic for nervous cases marked by minor pelvic lesions, but cautioned that any gains in health are temporary. Quote, we know that if we put them to bed, give them massage, electricity, and force feeding, we will practically cure them for the time being. And relapse is a real question here about the rescue, absolutely, whether or not patients relapsed. In opposition to this view, the neurologist, quick to point out that nervousness plagues men just as frequently as women, vowed to emancipate the nerves from the pelvis and treat them as networks, crisscrossing the entire body. These networks, they argued, are treatable through the rescuer's combined techniques, which they claim produced visible evidence, again, evidence here, of its efficacy in the positive alterations to the body's surfaces that ensue. The neurologist enumerated numerous structural changes the rescue produced in the afflicted patient's body without recourse to the knife. Fat and blood returned to squeeze out and wash away all vestiges of nervousness, even when the disorder was purely functional. One neurologist provided a series of verbal sketches describing the effects on patients' minds and bodies by the injudicious use of gynecological procedures. After listing the harm caused by, quote, the unnecessary handling and meddling with the genitalia, by the old practices of swabbing the cervix, of cauterization, or of penciling with iodine and carbolic acid, or by the more modern fad of introducing an electrode into the vagina, end quote, the neurologist composed a narrative detailing the enormous mental impression these procedures have on patients. Quote, not only is the great evil of the moral shock to be taken into account, but the fact that there is lodged in the patient's mind, more or less, vague but fixed idea that she has some mysterious local disease to which she only too willingly agrees to attribute her nervous manifestations, end quote. This fixed idea works insidiously on the patient. The morbid idea thus implanted, he warned, and it is in his warning that he draws a correspondence between ideation and anatomy. That once it's implanted, it becomes hopelessly rooted. And once hopelessly rooted, the impression, unlike the supposed errant uterus, which routinely required a pessary to keep it in its proper place, became a tenacious occupant, more permanent than actual tissue, quote, never perhaps to become displaced. And William Playfair wrote about what he called pessary on the brain, this notion that you had to have mechanical interference in order to rectify the nervousness in women. And what's interesting, back to the question of evidence, often female patients welcomed a gynecological diagnosis of some kind of misplacement because it affirmed that their mental health was rooted in something physical, right? And I think we have echoes of that still, right? That we want some kind of evidence, empirical evidence, some proof, something we can point to that justifies our mental state of being. Gynecologists skirt, for the most part, the neurologist's charge that unnecessary local treatment lodged morbid ideas in patients' minds, although they did not discount the power of suggestion, they merely reversed its outcome. Quote, remarks prejudicial to operative treatment act by suggestion upon neurasthenic and hysterical patients, end quote. What the consequences of this reversal may be, the gynecologist failed to name. Nowhere in the responses did gynecologists dislodge the portrait of patients suffering from anguish caused by the injudicious use of pessaries or other local treatments or surgery, to which the neurologist directed their critique. Mitchell's influence is palpable throughout the symposium. His method of viewing signs evident across the surface of the patient's body as symptomatic of her nervous system may not have convinced all of the participating gynecologists to put down their speculums and knives. But the doubts raised by neurologists and the dramatic recoveries they reported achieving through the rescue challenged the theories upon which late 19th century gynecology made female nervousness intelligible. Although Mitchell is guilty of collapsing distinctions between interiority and exteriority, a failing most critics of his treatment focus upon, especially those who read it through the prism of Gilman's The Yellow Wallpaper. The theory and the practice of the rescue, however, did make significant advances in distinguishing between a woman's temperament and her reproductive organs. So to conclude, I am not, by pushing against some of the more canonical readings of the rescue by humanities scholars playing another kind of game, that is naughty humanities scholar, right? I'm not doing that. But I think it's an interesting lesson that comes from a discipline that typically criticizes medicine, right? Is look at how within the humanities evidence can be read in very conflicting ways, in ways that serve a purpose, a pre-established reading of the cure based on story, the yellow wallpaper. And for me, what's very valuable about that is how often we enter a situation, and I'll be specific, a clinical situation, in which we take visible signs and start making an assumption based on that.